almost everyone comes in saying, I've tried everything, and they haven't. And it's important for them to know that you have to help patients overcome what at that point may be their own hopelessness.
Right.
One of the things we're interested in our program is, can you sequence things, even things that have already been tried? Would they work after something else? The atmosphere of the brain has changed because of something you did. They may not be all better yet, but then you bring back something else, and that may bring about further improvement.
Welcome to Insights on Psychiatry. I'm your host, Dr. Charlie Marmer, Chair of the Department of Psychiatry at NYU Grossman School of Medicine. And today I have the pleasure of speaking with Dr. Joshua Berman, who is an associate professor in our department and directs interventional psychiatry for NYU Langone Health. So, Josh, the focus of our podcast, broadly speaking, is on understanding how to care for complex psychiatric illness, particularly the patients that are diagnostically challenging and don't necessarily respond to the kind of normal pathways for evidence-based care.
There's a whole range of levels of invasiveness and precision and location. If we go over to the pharmacological side, we're talking about things like ketamine and S-ketamine, and someday I think the psychedelics, where those become interventional because the patient is in an altered state during the treatment. And here what I'd say is the interventional approach, and it's true for neuromodulation as well, it allows us to go outside of what we normally do by carefully timing targets, timing intervention when we do interventions, and having medical supervision for the interventions. We can do things that are beyond just what you can do when you prescribe a medication or do psychotherapy.
Perfect. So you've had 25 years of experience, have been a major leader of interventional psychiatry in New York in your previous work at Columbia before we were very fortunate to recruit you to NYU Medical Center. In your experience, if you were to discuss kind of a composite case briefly, not to disclose, obviously we're very sensitive about patient privacy in all of medicine, especially in psychiatry, but if you think of a composite case of someone who's complex and has had difficulty, even though there's been a number of efforts to care for them, what would that case look like? What would briefly their typical history be? And how is interventional psychiatry a new answer to an old problem?
So, it really starts with good evaluation. The idea is you want to understand how that patient got to the point where conventional treatments are not helping them. And by the way, whole other discussion, there may be instances where we're too hesitant to bring in interventional approaches, and there may come a point when we start to bring them in much earlier in the treatment algorithm. But right now, usually patients have tried a few different medications, maybe one or more modes of psychotherapy, and they're stuck. They're either stuck because they've been ill for a long time and haven't gotten better, or because they're having repeated bouts of illness. And whatever they're taking, maybe they get better briefly, but it doesn't hold them. And, so you do a good evaluation. You want to know, one, what's the pattern of their illness? And are there pieces of the picture? Maybe there's occult bipolarity. Maybe there's a comorbidity that nobody has paid attention to and needs to be addressed in a different way. You want to know what treatments have been tried. And often there's holes in the psychopharmacology. We don't do an interventional treatment for everyone who comes to us. Sometimes we say, you didn't try this. There's a particular class or combination of medications or a particular kind of therapy. So you want to understand what their treatment history has been. And then you actually want to get a thorough medical history, because that may determine what interventional treatments are going to be least risky for them as opposed to most risky. And so there's specific questions you ask that have to do with each particular interventional treatment, like seizure risks for TMS or blood pressure sensitive lesions for ECT, things like that. And then you have a stage where you talk to their therapist and their psychiatrist. I believe it's really important as an interventionalist to involve the treatment team and to create a sort of continuity in the patient's care. Interventions are time limited, and then they're going to go back to their regular treatment and be maintained in some way. We try to then work with the patient to get a sense of what their priorities are. Because right now, unfortunately, I can't tell you which treatment's going to work. There's two things, though, that happen. One is almost everyone comes in saying, I've tried everything, and they haven't. And it's important for them to know that, you have to help patients overcome what at that point may be their own hopelessness and desperation. You don't want somebody going into a treatment thinking this is my last hope, because it almost never is. And I'll get to that. Even things you've already tried. There's one of the things we're interested in our program is, can you sequence things, even things that have already been tried? Would they work after something else? The atmosphere of the brain has changed because of something you did. They may not be all better yet, but then you bring back something else, and that may bring about further improvement. So you get a sense of where they are in terms of their expectations for treatment, and you have to understand what's their biggest concern. Some people want to go with the thing with the highest response rate first. Some people are more concerned about managing risk, and they want to do the least invasive thing first. Some people are looking for speed, and they want to do the fastest treatments first. And some people are looking for durability. They don't want to be tied down to something that has a long maintenance period, if possible. And so they want to do the thing that's most likely to last.
So that's very interesting. So when you think about the broad field of the emerging field of precision psychiatry, as we move to be closer to the very high standard of care in oncology or cardiology, where each patient with breast or prostate cancer receives a genomically informed, personalized treatment. We're not there yet in psychiatry, but you're raising an interesting point, which is precision medicine means not just the ideas the doctor has, but precisely understanding what makes sense to a patient. Exactly.
And, the patient's expectations, fears, and hopes during a treatment are really important. And in our field in particular, have a big impact on outcome. The precision point's interesting because I think we have a bigger challenge than many other fields, in that I think a lot of the time we're treating syndromes, and we're not yet sure what the structure of those syndromes are. You look at heart failure, there's a number of discrete different causes with a final common pathway. And if somebody's in pulmonary edema, you do the same thing no matter what, but then then you go in and figure out why are they in heart failure, and you try to address that. We may not have exact categorical causes. Our precision medicine may turn out to be very different because it may be a spectrum of underlying causes coming together. And that is one of the things that makes me interested in combining interventional treatments in sequence, which is something we haven't done that much of, but we're starting to think about. So the idea being, patients have many, many different vulnerabilities that predispose them to developing an illness. And I mostly focus on mood disorders, so I'll just use the example of depression. Sure. We think about a failure of pathways that support neural connectivity in the limbic system, which is the kind of behavioral and emotional system in the brain. And we think about maybe another category would be failures in what I call the switching neurons, the big inhibitory interneurons that kind of are like the conductors. And there's probably lots more. But we know of many, many different ways that people may be vulnerable to having problems in these circuits. And the thing is, they can have more than one. So a particular treatment may rely on going through a functional pathway to a certain point, they may have something that blocks that. And so that may mean you have to fix one thing with one mode, and then you have to come in and fix something else with another mode in order to get those last group of people to be responders and remitters.
For example, if someone has difficult to treat refractory depression, you might have to tune up their medications, augment their antidepressants with thyroid or lithium or something else, neuroleptic, and then think about TMS with that.
Right. And there's even starting to be hints. There's a small group of people who they don't respond to ketamine, they don't respond to ECT, but if you alternate the two, they do better. And that to me says there's more than one box that's locked with the key in it, and you have to do something that, you have to unlock the boxes in the right order and get the keys out and unlock the next box.
I think that becomes, in some ways, the art of complex treatment as well as the science. The field has so-called treatment guidelines, which are very hierarchical and prescriptive, but don't address the complexity you're mentioning. But how do you see the limitations of treatment guidelines when you think of interventional treatments for depression?
So you raise an interesting point, and one of the interesting points to me is that interventional treatments differ from other treatments, and they have more degrees of freedom. So when you have a medicine, if you look at the half-lives of medicines, basically there's a dose and maybe how frequently you take it, and you're going to reach a steady state, and that's that. And those are the degrees of freedom. When you're doing an interventional treatment, particularly a neuromodulation treatment, you've got amplitude of the stimulus, location of the stimulus, pulse width, frequency. And that's not to mention, how many times a day or a week do you do the treatment? How many in succession? When do you stop? When do you taper? And it's almost impossible to test those things in the framework of clinical trials that we have. So, people pick what they think is going to be the best combination of all those things, and they test it against some kind of sham treatment, and they have a built-in kind of measure of usually it's whether people think they're getting sham or not. If they're not better than chance, then your sham worked. But you test things that way, but there's very limited. We don't have enough universes to test all the possibilities. So the guidelines that exist are, they're important, they're reasonable, but they're also based on very limited information. And sometimes you have to have ways of going a little bit outside of those guidelines, but you have to think about how you do it. You can't just be,
right.
a cowboy.
So we don't have 3 parameters to vary. We might have 100 parameters to vary, and that's part of the complexity. 10 years from now, what kind of really cool new ideas will there be in intervention that you'll be, like, for example, ultrasound or other things that will change our field?
You mentioned ultrasound, which is potentially one. That allows modulation, and because of the nature of ultrasound, you can actually reach deep targets in the brain, which you can't easily reach with TMS unless you use deep TMS, but then you lose specificity. Ultrasound gives you specificity and depth, and that can modulate circuits. The other interesting thing about ultrasound is that it locally opens up the blood-brain barrier a little bit and may actually allow brain markers to circulate in a way that we can assay them so that we could get localized biochemical information about brain regions of interest non-invasively. So that's one thing. I think our ability to guide the treatments we have, like TMS or ultrasound, will improve as we get sort of scalable markers that are devised from brain imaging. And what I mean by that is, the best brain imaging markers are from resting state connectivity measurements in fMRI. That requires somebody to sit in an fMRI for 20 minutes or more, and then the data has to be crunched. Although I think over time there will be better ways to do that with automation, it's still not the most scalable thing. But I'm going to take the example of PRISM, which you're very familiar with. It's a EEG-guided neurofeedback technique and is part of our armamentarium now. the people who developed PRISM used fMRI data, but then they managed to correlate it with an EEG signal that's very easy to acquire with very inexpensive equipment. And what that allows is scalability. The ideal is to have things in a doctor's office that they can personalize your treatment with. Another one is FNIRS, that's functional near-infrared spectroscopy. And that's sort of like having a little brain imaging module in your office. Now, right now, it's not quite that scalable, but people are working on FNIRS units. So imagine I'm doing TMS. I put down an FNIRS unit on one part of your head, and I'm doing the TMS on the other, and I look at it, I say, oh, we're not getting quite the signal we need, and then I move it. So, that kind of thing is coming.
So FNIR is an MRI in a box.
It's moving in that direction.
It might become one. By the way, on the PRISM neurofeedback, Dr. Thomas Hendler developed this in Israel and had the idea, which was some other investigators also, to simultaneously acquire EEG while the patient's in the magnet, so you could find a simple EEG signal to correlate with that, and then you can do that work in a private practice office.
And now that that signal is used to power the virtual reality computer program that the patient interacts with in a neurofeedback, where they kind of learn to enhance activities that are therapeutic for anxiety, for trauma, for depression.
For example, to exercise the brain circuit of emotion regulation.
Exactly.
And cool down their amygdala, which is the next. That's now we're thinking about the future of psychiatry,
And by the way, those signals can probably be acquired and used in other treatments. If the patient doesn't happen to respond to that treatment, those signals still may be useful.
So we do offer TMS, we do offer ketamine, we do offer PRISM neurofeedback, and we will be offering ultrasound in the future in our program.
Yes, we're in the early stages right now of assembling everything, but what we're going to have in short order is a program that offers all the different modalities, all the way up to neurosurgical intervention.
Right, with deep brain work.
And I think I want to mention, I think that's important, that we be comprehensive rather than be sort of TMS specialists or ketamine specialists, because I want us to be patient-centered. And, the patients may come in with a particular idea of, oh, I heard about this, I think it's interesting. And they're often right. But the idea is to be able to present patients with a range of options. And also, if you have all these things, you can start to combine them. If you're only doing one thing, you can't really combine them.
So we're going to need to stop today, but we'll have you back. But just on a historical note about, is it the tool or is it the field, right? If the railroad barons at the end of the 19th century understood they were in the transportation business rather than the railroad business, they would have owned all the airlines because they had all the capital. But they thought they were in the railroad business.
Right.
So we don't want to be in the TMS business. We want to be in the understanding of the deep aspects of brain function that will allow us to use any set of tools in any safe combination to help the most complex patients.
I couldn't have said it any better.
Thank you very much. It's been my pleasure. Dr. Josh Berman, our newly recruited head and leader in interventional psychiatry. It's been a pleasure speaking with you.
Same here.